So hello everyone. Sorry for the little delay there. We were just waiting for some more people. First of all, welcome back. I think the last time I saw everyone was at the end of July, I think it was the last time we had our webinar. So welcome back. My name is Mohsen Salim. I am a final year medical student and also one of the project managers here at Study Medicine Europe. And this is our sub-department called SME Symposiums. And as most of you already know, what we basically do is informational and educational webinars every month on various different topics. So today we have something really, really exciting for you, and it's basically going to be about mastering medical school. And even more exciting than that is the person we have talking about it. So Dr. Baskaran, I could never pronounce his surname. You will forgive me for that, I hope. But basically, I met Sorubaan a few weeks ago when I was doing my placement in Basel University Hospital, and he had some amazing thoughts and ideas on just general advice to students that's helped me a lot, and I feel like it will contribute to everyone here. So just before I hand it over, I just want to give a big thank you to Lectorio, our partners and our sponsors. So Lectorio is an all-in-one study resource for medical students that combines learning science and medical education into one easy-to-use platform. I'm sure you've heard me say that every single time. But honestly, they're great. I think for this time round, we will not have our code available. I think there were some technical issues with that, but that will get sorted out for next time. As well as the 6 months free pass handouts. So without further delay, I'm going to hand it over to the good doctor and he can take over from here. Thank you.
Welcome everyone. I'm Sorubaan Baskaran. I'm an FY2 doctor at Basel University Hospital, which is part of Essex, Bedfordshire and Hertfordshire Deanery. I'm in the FY2 standalone program at the moment and currently doing my placement in trauma and orthopedics. And then I'm going to move on to internal medicine from November to March and then GP from April to August. So essentially today's webinar is about how it's a setting up as for success as a medical student, but essentially it's about how I did things to make me, to prepare me for working as a foundation doctor and what I'm doing now to prepare me for further specialization in hopefully next year. So without further ado, let me just get started. Sorry. Yes. So this is a quick timeline of my career so far. It's not been long. It's been 8 months. But this is a quick overview of what I've done. Most of you know that I studied in Sophia Medical University from 2014 to end of last year. As soon as I graduated, I got a trust post in King George Hospital as an FY1. And then from April to August, I got a trust SHO post in Nottingham University Hospitals to do in general surgery. After that, I moved on to my FY2 training program, a standalone program, and that's where I am now. We're in trauma and orthopedics. Like I mentioned earlier, I'll be moving on to internal medicine, then GP. That's a 1-year program that encompasses the foundation program because, as we all know, our degree includes technically includes the FY1 year. So we're exempted from doing the FY1 training year. Hence why I moved on to the standalone program. So how the structure of today is going to work is I'm going to first talk about what things I've done as a medical student to help me sort of prepare me as a doctor today, and what I'm doing now to sort of help me into my training program in the future. So first of all, yeah. So what should you be doing as a medical student to prepare for a career as a doctor? Medical students in Europe emphasize a lot on theoretical knowledge. I think we all know that, but that's completely different to the NHS. In the UK, medical students focus a lot. The training, medical training focuses a lot on practical-based, problem-based learning. So our learning is very traditional, where we do 3 years of preclinical work and 3 years of clinical rotations. Here, they go into hospital as early as first year. So, for example, they'd be starting to learn about the arm, for example, and they'd be learning about the anatomy, physiology, pathophysiology of the arm. So they wouldn't learn about anything else first. They would just learn about system-based learning. Whether that's right or wrong, that's a lot of people debate about that, but that's an example of how practical their learning is. So as most of us want to transition back into the NHS, we need to constantly be thinking about how we could be accustomed to all the practical procedures and their practical way of thinking. When we study, we need to be learning about how we can sort of transition back. But the advantage we have as for international medical graduates is our theoretical knowledge. I think you can ask most doctors working in the UK now who graduated from Bulgaria or Bulgaria specifically, is their theoretical knowledge at the very least stands toe to toe with a UK UK doctor. And that's again that goes that's the reason is the theoretical knowledge is what our emphasis is on. So our so what we can control in medical school is getting our theoretical knowledge very thorough. So that moves me on to the next part, which is the practical part. So during our summer holidays or during whenever we've got time off, I've done 2 clinical attachments prior to graduating, and this goes beyond what it's going to look on your CV, because of course it looks good on your CV and whatnot, but it's more about what we're learning and the connections we make with other doctors, other medical students. I made more connections with medical students and doctors during my elective time period than I did like I did during my medical school, which is which is really really useful. My first FY1 post in King George Hospital actually came as a result of one of my clinical attachments I've done. So I really urge you guys to go out of your way and organize one of these clinical attachments, because they're very useful. They urge you to do practical procedures. They urge you to take blood. They urge you to catheterize. They urge you to take history, clock patients in, admit patients. These are all things that we don't get to do during our medical studies in Bulgaria or any other, I can speak for Bulgaria in Sofia Medical University. So I know how difficult it is to get elective placement, but I would say, like Mohsen, I spoke to Mohsen when he was doing his elective placement. He just told me, look, I emailed a lot of hospitals and one of them was bound to email me back, and he did. And he was doing a clinical attachment when I came across him in one of the wards. So the more you try, the more chance of you're going to get it. So I'd urge you guys to please do a clinical attachment during your summer holidays. The other thing is, during medical school, I got involved in a charity, some of you might know, Medical Students on a Mission. And that helped me more than what I thought it would help me with. So it was more than, helping out people. Our charity mainly focused on screening programs in Bulgaria, Nepal, and Nigeria. But what it ended up doing is, during our camp, we ended up doing data collection, and we published 2 research publications in Berlin. This, number one, showed me how to go through the publication process and help me with publishing and get it certified in a journal. Number 2, obviously helped me with my CV. So there are unseen, non-tangible benefits to being involved in charities or other organizations that help you with your progress. I was also involved in different societies, which is like non-medical. I was, for a long time, I was doing events, which is not connected to medicine at all. And this, you can be involved in a lot of different societies, and it doesn't have to have direct benefits to medicine, because when I was doing events, it had nothing to do with medicine, but it showed me people skills. And working in the NHS, I know a lot of people talk about people skills and teamwork, but it's so important. I can't stress to you how important it is to talk to different people. You talk to different people in different ways. You talk to a consultant in a different way to you speak to a registrar, to you speak to your colleagues, you speak to your nurses, to healthcare assistants, to even like cleaners. there's different forms of content. It's about emotional intelligence that this all these different involvements help me out with. So whatever opportunity you get, as long as it's not impacting your studies, I would say, get involved in, and you'll reap your benefits. And the final part is build just mental stamina, because working in the NHS is not easy. Trust me, it's not easy. Long hours, and you just go the whole day, and you sometimes you have really bad days, sometimes you have really good days, but mental stamina, there's a difference between stamina and sprint. I mean, the sprint and a marathon, for a marathon, you need stamina. And, just think of working the NHS as a long race, and you need stamina. You need to just keep going every single day, just keep pushing yourself. Again, doing all these different things and going through, good and the bad thing, going through all the good experiences and the bad experiences, it really does push you to just keep going. Because at the end of the day, we all have a dream, and that also pushes us, but we need to have a reference point. If we've got a reference point in the past, we've done this, we've experienced this, it's obviously going to push us. So next, I'm going to move on to what's important as a foundation year doctor. What I'm doing now as a foundation year doctor, that will sort of set me up in my training program, my specialization. So like I said earlier, as international medical graduates, it wasn't meant to say IMTs, it was meant to say IMGs. So international medical graduates, we are in a disadvantaged position. I've got to be honest. So we are in a disadvantaged position, both in a career progression point and in sort of our experiences. The quickest way to stand toe to toe with UK doctors is getting into a training program. So I can't emphasize how important it is to get into the foundation program, or there are other programs like the Gateway program or whatnot. Getting into a program allows you to have proper training and proper service provision. Service provision is just your work, but proper training, that's the most important part. And the most important part is you getting the sign off and getting the FPCC certificate. FPCC certificate is the Foundation Program Competency Certificate, which is just literally the gateway to you starting your specialization. There are more things to starting your specialization, and that depends on what career path you want to take. But the FPCC certificate is very important. I know there are other ways, like I believe it's called a CREST form, and that's also a valid route. But for me, from my experiences and speaking to other doctors, FPCC certificate is key for me. That's what I found. Foundation year, a lot of international medical graduates I found just overlook the foundation years, and they just want to move on to their specialized, their training program, which is sort of ST programs or CT programs. I personally think that's the wrong mentality, because the foundation program is essential to our progression as doctors. You don't find a registrar who isn't as competent as a foundation year doctor. And that's really important, because for you to pass each stage, you need to master at each level. You can't go from studying in Bulgaria to straight away going into your registrar post. It just doesn't work like that. It's not meant to work like that, because you will be found out at some point. Your gaps in knowledge and gaps in experience will show up, and it will cost more when you're higher up than when you make mistakes when you're a foundation doctor. It still costs me more. Like, it still costs me as a foundation FY2 doctor, but it's going to mean less because I got the protection of a registrar or consultant. Imagine you find yourself as a registrar, and the only senior person to you is a consultant. You make an error that a foundation doctor won't make. These are career-ending errors. I know people who've lost GMC license because they've made simple errors because they've skipped important steps. And like I said, I can't stress to you enough how important the foundation years are. And they will be difficult. They're meant to be difficult. They're meant to be long hours. They're meant to be a hard slog, but they're meant to help you in the long run. For example, myself, I chose DT rotation, trauma and orthopedics, internal medicine and GP because I wanted one surgical, one medical, and one community. I wanted to sort of cover all bases as well as getting my training done as efficiently as possible. That moves me on to the third part, which is an Ehoras portfolio. Some of you might have heard about this, some of you don't. I'll do a quick run through of what the Ehoras portfolio is. Horace portfolio, this is sort of, this is my portfolio. It's basically an online platform that monitors your progress. So only you and your clinical supervisor or educational supervisor will have access to it. And you need to have certain sign-offs. For example, when you have a complex patient, you have to discuss, it'll be good for you to discuss with a registrar, and you get a sign-off it's called a mini KEX. Or you have a case-based discussion and you get a sign-off from there. Or you can do adopt, you do procedures, you do take bloods, you put cannulas in, you get sign-off from there. All these sign-offs mean something. You need to have a minimum number of sign-offs for each of these different things for you to progress into the next stage. And again, like I mentioned, you need to have all these different sign-offs for you to move on to the next rotation and eventually to finish your foundation program. I probably will do another talk on Ehoras portfolio because that's a whole different sphere itself. But all you need to know for now is Ehoras portfolio is an online platform that monitors your progress, that requires you to have certain number of sign-offs for you to move on to the next stage of your career, because these are the minimum requirement. They're called the ARCP requirement. These are the minimum requirement you need to be a competent foundation year doctor to finish your foundation year training. Like I said, I'm going to move on to the Ehoras. I'll probably do another talk on the Ehoras portfolio in the future. The final thing about the foundation year doctors is being on the OnCall Rota. The OnCall Rota is essentially so FY2 doctors are known as the old term SHO, senior house officers. Their senior house officers encompasses FY2, CT1, and CT2. And SHOs are the level below the registrars. And often what it means to be on the OnCall Rota, especially in orthopedics, is A&E, you've got the on-call bleep, and A&E are always on the call to you, on the phone to you. They say, look, there's a patient who's come in, he's at a 4, he's fell on the right arm. Essentially, what you have to do is, first of all, understand if this is even an orthopedic issue. Sometimes they just give you random calls, you just have to reject it. You have to say, no, there's no orthopedic issue, you've got to call so-and-so. But once you do figure out this is an orthopedic issue, it's yours and your registrar's decision to have a look at x-rays, have a look at all the scans, go down to the A&E, see the patient, clock the patient, see if you can reduce the issue. If there's a dislocation, if there's a fracture, maybe you can reduce it, put a cast on it, put a sling on it, and send the patient away and bring them back in for the fracture clinic in about 2 weeks. Or if it's really serious, if there's neurovascularly compromised, you've got to take them into the theater. Okay. This is what it means to be in the on-call rota. You're always being on call. In fact, I'm on call from Monday to Thursday this week. And honestly, I can't say any good things about it. It's chaos. The whole hospital will be calling you. You're the only number. Yours and the registrar's bleeps are the only bleeps. If it's trauma and orthopedics, they're going to call you. If you're the on-call SHO, they're going to bleep you, or they're going to bleep the SHO before they bleep the registrar. So I can't say any good things about it. All I can say is you learn the most during your on-call rota. When you do on-calls, you learn the most. You're stressed. You do 13 hours continuously, maybe more sometimes if you have trauma calls. But you learn the most, and that's what it's meant to be as a foundation year. You just learn, and you're overworked. Okay, that moves me on to the next part, which is looking ahead. Looking ahead. Now that I'm a foundation year doctor, I've got my eye on a training program. Okay, I'm not going to say what it is, but I've got a specializing program in mind. I've got to cater my portfolio to be enough to apply for this training program. And I've got certain things over here. Well, these are the 6 main things. It doesn't matter what training programs it is, apart from GP. These are the main things that you require to sort of progress on. So you need to have a certain number of audits, you need to have publications, you need to have presentations, you need to have teaching programs, courses, and it will be preferable if you have any prizes, okay? And these are all things that you need to be, as well as working as a doctor in the NHS, you need to be having an eye on progression as well. So for me, so I'm planning on applying for my training program this November, and I'm planning on getting a London placement for my training program. So already I'm in like I said, I'm in a disadvantaged position coming from Bulgaria. And on top of that, this is my first month in training, and within 3 months' time, I've got to apply for training programs. So I've got to work 3-4 times harder as someone who's already been on training program for a year and a bit now, and someone who's had 5-6 years of medical training in the UK. So, and on top of that, I want to get a London placement. So I mean, I'm so far behind. I'm not far behind, but I've got so much catching up to do, and I'm doing what I need to do for my training programs. And these are the main things: audits, publications, presentations, teachings, courses, and prizes. Okay, for example, if I'm going to be honest, I'm going to get prizes if I'm going to get points for this for doing this presentation. And I'll be getting I'm involved in publications, audits, I do teaching programs, and I've been to a few courses. So always have an eye, I'm not asking you guys to know exactly what you want to do in in terms of specialization, because that would be very unfair. You guys are studying in a country abroad, and it's unfair to make up your mind not knowing how it is to work in a certain specialty in England. Maybe that's the main reason for you to do an elective placement in that sort of specialty. So if you want to do a certain specialty, do a clinical attachment in that. But like I mentioned, audits. So if for those who don't know what audit is, well, it's fairly simple. Audit is, we've got, every hospital have their own guidelines and way of doing things. So you basically you see if there's a certain specialty or a certain ward that don't follow these guidelines, for example, and you take data. Say, for example, I go into a ward, and it can be as simple as a ward doesn't give antibiotics to patients on time. And if I notice this over a while, I take evidence, I take data collate. Okay, this, it is. I take enough evidence, and I, speak to my consultant about it. And then after that, I can put an intervention in. How can I improve this situation? So do a pro forma. All the nurses have to tick at a certain time they've given the antibiotics. And when this is done, I'm going to do another data collection to see if my intervention has worked. And if it has, I've succeeded. My audit has worked. And even if it hasn't worked, it's fine. It's an audit, and you present it, and that's a presentation. Publication is a bit more extra. You have to have an interesting, you need to have an interesting idea in mind, and you do data collection for that, and you publish in journals. You have to go for statistical analysis, which is a bit longer, but you get more points for publications. Teaching programs, you essentially teach juniors or your peers in a certain topic. If it's international, you get more points. If it's national, more points. And courses, you attend different courses, and prizes. Well, if you get any prizes, it's obviously very good. Sorry. So that brings me on to a day in the life of the F2 doctor working in trauma and orthopedics. Okay. So, like I mentioned earlier, I'm going to go through OnCall Rota, which is the most interesting one. So if I'm on call, so for example, on Monday, I'll be in a trauma meeting. I'll be in a trauma meeting with my consultants. So 3 consultants, 3 registrars, 4 SHOs, and there'll be no F1s. F1s don't attend the trauma meeting. And what we essentially decide is, from last night, from the last 12 hours, who are the new admissions? Who are the people who are going into the theatre? And if there are registrars who are available to do the procedure, or the consultants, usually the consultants don't do it. First, the registrars do it. If it's complicated, the consultants do it. Normally, the registrars and SHOs do the procedure, then the consultants come in. So the first part is doing the trauma meeting, which is discussing all the cases that have come in, all the cases that go into theatre, all the patients that are already in the wards, any complications, anything that's happening, we discuss it. Number two, you have the SHO bleep. This is my SHO bleep. So actually, no, this is not my SHO. This is my personal bleep. SHO bleep is more of a baton bleep. So it gets passed on. So the night doctor will give it to the day SHO doctor, then move on to the night SHO, then, it just gets passed on. So you'll be carrying, when you're on call, you carry two bleeps. So SHO bleep is the bleep I was talking about earlier. Every nurse, every healthcare, every doctor knows the orthopedic SHO bleep. That's why it's really annoying, because they call you for random stuff. They can call you for, a patient's come in and their arm hurts. You've got to be like, no, I'm not having this. Has there been an X-ray? Has there been bloods done? You look at the X-ray. You have to basically make sure you tell them, I'm not accepting this patient until you see the X-ray, you see the CT, you see the bloods, and you be like, okay, I'm going to come and see the patient. I'm still not accepting it. Then you go down to see the patient and you realize, okay, this patient has nothing. He can just go home. The patient's got no fractures. Or in the worst scenario, the patient's got fractures, got dislocations. You try and manipulate it. You try and reduce it. And if that kind of happened, like I said, you get admitted into theatre or admitted into the ward. Again, like I mentioned, trips to the A&E, you're gonna, when you're carrying the SO, when you're on call, you're constantly going down to the A&E. You might as well stay in the A&E, to be honest. You go to the A&E, you see the patients who've come in with all the fractures, dislocations. One thing I didn't mention here is the trauma calls. Trauma calls, if there's an accident, if there's a major event. There was a Stansted airport, there was a flight that landed incorrectly, and there were people in, there were people injured from that, and people just coming to Basildon because that's the closest hospital to Stansted Airport. All these different major events, orthopedic team will be alerted, and 10 minutes before they come in, you'll be you'll be having these, your bleep will just be going crazy, and you've got to go down to the A&E. Next part is reduction or admissions. Like I said, you either reduce it, put the patient in a cast, you put the patient in a sling. If that can't be done, you take the patient into theatres. And the final thing, like I said, is the theatres. That would be one of the theatre lists I done. Orthopedics, this is actually one of the general surgery theatre lists. Orthopedics is more gruesome than that. This is probably me looking at one of the scans, chest x-rays. This is also in general surgery. This is just what it is to be a SHO on call. You're constantly carrying bleed. You're constantly, it's fun when you look back on it, but when you're doing it, you just, it's not the most fun thing to do. Okay. Finally, I think it's important for me to also talk about why is it important to strike a balance between work and pleasure. Because as I mentioned now, being on call or working the NHS, as a matter of fact, it's highly pressurized situation. You're always demanded to be on time. Sometimes you go days, sometimes days without having lunch, and you've got to do these things because essentially, like, your whole department relies on you. So you've got to have things in place for you to, take your mind off and compartmentalize work from pleasure. So what I mean by that is, I know it's very hard. I know it's hard to, I know a lot of doctors struggle with this. You've got to leave work at work. There are days where I come home and I message my colleagues, my night SHO or my colleagues, and say, look, what's happened to this patient? Has this been done? This been done? That's really bad. You should not be doing that, because if you carry on doing that, it's just not good for your mental health or your physical health, as a matter of fact. When you leave work, make sure everything that needs to be done is done. And once you leave that door, you don't think about it until you come back into work. And that's something I'm working on as I speak. I'm much better than I was a few months ago, but I'm still a work in progress. Recuperation between on-calls and nights. It's so important to have hobbies that are so non-medical related. Again, that's something I'm still working on. I'm really interested in sports. I play a lot of sports. I watch a lot of sports. I think that's a sort of escapism for me. But it's really important to, when you come back from work every night, you need to have something to do before you go to bed, and it's something I'm working on. And I recommend you guys as medical students or even young doctors to think about these things. What am I going to do when I come back from work that's going to help me sort of keep me at peace from my day at work? The other thing is working in the NHS is threefold: service provision, progression, and obviously the pleasure part. Service provision is when you go into work, the service you provide. So when you work, when you're on OnCall Rota, when you're on the wards, you do your best. But you've also got to think about your progression. So when I mentioned earlier, when I spoke to you about your Ehoras portfolios, your Ehoras portfolios, your how to get involved in audits, publications, presentations, you've always got to have an eye on how can I get involved in these things, as well as providing the best possible healthcare I can. This is really important because once you finish your training pro, say I'll finish my FY2 program, you've got to keep progressing. You don't want to be in a situation where you finish and you realize, oh no, I wish I concentrated a lot more time on my portfolio, or I concentrated a lot more time on, doing publications or presentations, because other doctors, a lot of other doctors do. A lot of people take time off work, take study leave, take annual leave to specifically focus on their progression. And the third part is pleasure. So it's always, we're at the beginning of our careers, and it's really important to know that. And once we know that, it's really important to take it quite steady. It's not about peaking right now. It's a marathon, and you've got to peak in about a few years' time. So, take time out. If you can't do something, if you need some days off, take annual leave, as long as your rota coordinator agrees to, just take it easy as much as you can, as well as doing the best job possible. Coming out of training program, taking years out. Okay, yes, this is something I spoke to you about earlier. A lot of people finish the FY1 and FY2 program and do F3 year, which is locum year, F4 year locuming, and often find themselves just keep doing locuming without getting into a training program, without getting into a specialty. And this is, personally, I can't speak for everyone, of course. Personally, I would recommend it. I would say that's something you should kind of stay away from, because once you do, we can do like F3 year where you locum, but once that becomes a habit, a lot of people just get stuck in that, cycle of doing locuming. The best thing about that is think about the specialty programs you want to do and just start preparing for it from now on. And finally, it's very important to do what you love. Healthcare and medicine as a whole is a hard slog. It's long. It's going to be, you're going to have a lot of sleepless nights. You're going to have a lot of days where it's just not going to be very happy. So it's very important to do what you love, have an end goal, because that's always going to keep you focused. So that's always going to keep you motivated. I think that's all for me for now. That's my team from my general surgery in Nottingham. That's all from me for now. And if you guys have any questions, I'm more than happy to answer. Thank you.
Right, guys. Well, first of all, thank you so much, Dr. Baskaran. That was very enlightening and a very, very interesting talk. Guys, I would encourage you all to please fill in the feedback form. We thrive on feedback. We use feedback a lot, and it helps us develop more and more for every webinar. So what I'm going to do is in the Q&A, you guys should be able to see the answered question. One of them will have the feedback form on it. Alternatively, you guys can use this QR code. So if you guys just pull out your camera on your phone, point it towards the QR code, it should automatically take you to the feedback form. It will be up in the Q&A in a second. So we're quickly going to move on to the Q&A, and I'll give everyone a minute to write their questions in. Whatever questions you guys do have, just ask away, and basically I will relay them to Dr. Baskaran, and he can answer them accordingly. Right, yo. I think we have some already. So are you okay to start, Doctor?
Yeah, of course. Yeah, let's go.
Okay. So what year is ideal to do a clinical attachment in?
So I would say, because, Bulgaria and international European medical schools follow a traditional pathway, is important. It's not, it's not useful for you to start too early in first year or second year. I would say third year onwards, third year, fourth year, fifth year, sixth year. They're the, fourth year onwards, I'd say would be the prime time for you guys to start. So you'll understand what's going on. You've got enough theoretical knowledge for you to put into practice and understand. I did one clinical attachment in first year. I'll be honest, I didn't know what was going on I did not understand what was going on. And then I did another one in fourth year. And that was more useful for me than the one I did in first year. So I would say definitely the ones from third, fourth, fifth, and sixth year, you guys should be thinking about doing clinical attachments.
I absolutely agree. I think I did one after third year. I think I just finished my general surgery module, and I went straight to a general surgery elective, and I really regret it because I feel as if I was there now, I would take so much more from it. Whereas I was just sort of walking around like a headless chicken. I didn't know what I was doing or what to expect.
Yeah.
So I think very early on, I completely agree. It gets a little sticky. It depends what you want exposure to. Like you were saying, in the UK, students get put into the hospital as early as first year. But I think it just depends what you're dealing with. I think when I was doing my clinical placement in the general practice, there was a second year over there, and it was his cup of tea because all you really had to do was, it was a lot of talking on the phone and there was a lot of paperwork. And I feel like, okay, that you can handle, but if you want to jump into general surgery after you finish second year,
Yeah.
I just don't think anyone has the clinical knowledge for that at that point.
You need to know the anatomy well. Like with general surgeries,
Yeah,
bread and butter anatomy, knowing what's going on. So yeah, no, 100%. Yeah.
absolutely, absolutely.
If not, you're just standing there, you use the wallflower, and you should not. When you're in clinical attachment, you try and get involved as much as possible. You try and get. If not, you'll just be a pointless experience. Try and get involved, and once you're through that door, just think, look, I'm going to do everything I can to be involved. I know people in clinical attachments who got themselves in audits and publications. This is, you've got to just maximize, you've got to squeeze every single thing out of it. And in any situation, whether you're a clinical attachee or you're a doctor, you've got to take every opportunity you can, because
they really don't come by every day, do they? That's the other thing. They really don't. I mean, a lot of people have been asking me how I got my clinical elective, and the truth was I applied for it 8 months before. So I was on their case very early on, and it didn't get sorted out until last minute. And I honestly feel like the only reason it did was because I just wouldn't leave them alone. That was it. I just kept calling them.
No, it's good. You've got to be perseverant. Like, you've got to have perseverance, and you've just got to keep at it.
Yeah.
You just don't take for no, like, just keep at it.
Yeah, literally. When they said, "Oh, AMU is not available," or something's not available, I'm cool. I'll do anything.
Yeah.
You see, I'll work in pathology at this point.
Get yourself through the door. Once you're through the door, once you're in the hospital, they're happy to just help you as wherever they need to help you out.
Absolutely, absolutely.
Get yourself through any hospital, any door. I'd really recommend it.
Absolutely. Somebody asked, what is Ehoras and why is it so important?
Okay, so that's a very good question, actually. Like I said, I didn't do a good job of explaining it, because if I tried explaining it, that would take hours. Okay, Ehoras Portfolio is like the online platform that UK for FY1 and FY2 doctors use. And this is a platform that, there are different sections of the portfolio. There are things called mini kexes, DOPs, CBDs. Mini kexes is if there's a complicated patient, you discuss with the registrar, and if he thinks you understood enough, if you help the patient enough, they give you a signature. CBDs are case-based discussions where you go into the depth of each case, not just the orthopedic part of it, or not the general surgical part of it. You go from A to Z, from the patient's history from 10 years and how that could have helped, well, that could have sort of impacted the patient to the situation he's in now. And the DOPS are direct observational procedures. So, if you do, a PR exam, that would be a DOP. Whenever you do these things, I used to just do these things and realize I just used to keep walking, and other doctors were like, when you do these things, you've got to make sure you get these sign-offs. You've got to have this thing in your mind where your progression is really important. Like I know when we're working as doctors, we just want to help people as much as possible. But we've got to help ourselves. We've got to make sure these sign-offs are done when they're needed, because you don't want to get to the end of a rotation and your clinical supervisor, who's your consultant, and he's looking at your portfolio thinking, what have you been doing? You could be the best doctor possible, but if there's nothing signed off, it doesn't mean anything, So Ehoras portfolio is literally your passport to your specialty program. So very important to get signatures, very important to keep an eye on whatever you're doing, get your sign-offs.
Absolutely. Yeah, I think even when I was doing my elective there and the electives I've done before, even if you can talk to whoever your supervisor is about it, even if you just want to mention their name, or even if it's something you want to sort of name drop in an interview, at least you have somebody's name and contact details they can call up and say, okay, if they want to check if it's legit, it's legit. I know some people who went around about that, but a portfolio, e-portfolio, can never go wrong for sure.
The e-portfolio, there's one thing about e-portfolio is it can never be done retrospectively. So you couldn't go to end of rotation and go to registrar. Oh, sorry. Do you remember that procedure we done the other day, 2 months ago? And he might remember it, but you can't sign it retrospectively. You've got to sign as soon as it's done. And you've got to be very present with these things. You've got to always have your progression in mind. So make sure these things are just on time, just signed off, and just forget about it.
Absolutely. I think somebody asked actually quite interesting question over here. I'm planning to study in Sofia Medical University. Does the university focus more on theory than the practical side of medicine?
Yes, 100%. Like I couldn't tell you how much they focus on the theoretical part. That's not me putting the university down, because that they're the reason I'm here in this situation, but they do. And that's both a blessing and a curse, because when you come here, you realize how advanced your theoretical knowledge is, but also you're compensating for your lack of practical knowledge. So again, it's your initiative, it's your duty to go out and get clinical attachments to compensate for your lack of practical experience. But in terms of theory, they look after you very well.
Mm-hmm. I can absolutely agree, coming from a different university in Bulgaria, because I study in Plovdiv. So I think there is a bigger importance given to the theoretical side of things, but that's not to say there is not the opportunity to do practical stuff. I've walked into hospitals and done a lot of practical procedures. I think the only difference is a lot of it is in your own time, and it's not something that's spoon fed to you. You really have to go out there and ask for it. I've never had no say to me. So if I ever walked into a hospital and it was one of my teachers and asked them, sir, can I do this? Or can I do that? I've never ever had no say to me, but I've had to go through the process of, in my own time, going in, finding them, asking them nicely, can I do that? And I think you just have to acknowledge that there's that extra step over there. I think the other thing is a lot of people aren't comfortable with it because of the language barrier, so it's very hard to get consent, so much as consent, if you don't know how to ask for it. And that can always cause problems. It helps if you have a good teacher who can translate for you, but then again, unlikely sometimes. Just before we do move on, I want to quickly remind everyone that the feedback form is in the Q&A answered section, so please do fill that in. I quickly want to ask someone, I've been having this question thrown a lot at me, so I do want to address it. Do we have to pay for doing attachments in the UK? So I'll let you go for this one first.
Okay, so I've had to pay, and I've had situations where I haven't had to pay. My latest one, which was I was doing an Imperial Summer School program, and in the 5th year in 2009, well, it wasn't 50. Yeah, it was in the 5th year. Yes, in 2019, and I was with Imperial College 5th year students, and I had to pay about £400 for that, and that was just health clearance, occupational, all those clearances, and I think it's also for insurance. Because you're not their responsibility, you're not part of their deanery, you're not part of their medical school, so they've got to have like a safety netting, and you're paying for that essentially. But the ones before, I never had to pay. I never had to pay. I was under the care of consultants, So, I mean, if you're shrewd enough to get somewhere without paying, kudos to you. But if you have to pay, I wouldn't say that's a bad investment. I would definitely recommend it. But yeah, I've had both.
Yeah. I think with mine's just about the same. And I think the way it's been explained to me is if you're going through the hospital administration, they have these procedures put into place already. So they'll hit you. Well, what happened to me was they hit me with a ridiculous price, and I'm talking three figures here. And they said it was for administration fees and to make the ID. I'm like, it's a piece of plastic. So I've at the same time, I think that the electives I had where I went through the consultant instead of going through the hospital administration, it was a lot cheaper for me to sort everything out, like literally like 20 or 30 pounds sometimes just to get an ID quickly made. So but honestly, I think like Dr. Baskaran said, because of our problem, one of the problems we face as IMGs is that our university does not cover us insurance wise when we are doing electives and placements over here. So that is something the hospital has to take on as vicarious liability. So, if they asked me for like double or triple the price, I would be more than happy to pay for it, because I know this is the reason a lot of us don't get placements, is because they're like, okay, you're an insurance risk. And the hospitals who are willing to oversee that and just say, okay, we're willing to take the responsibility, I would go for it, whatever the price tag on that is. Absolutely. So somebody also asked, are clinical rotations different from elective specialities that you recommend?
Sorry, could you repeat that question again?
Are clinical rotations different from electives? I think really is the question.
Clinical electives, are they different from rotations?
Yeah.
So
I think the question that I've even got a few messages from a few people asking a similar question about what's the difference between a placement and an elective.
okay, they're the same thing. They
Yeah,
electives, I think it's
elective
nothing
is
more.
a elective from what I know is just a medical word for a placement. So you can get placements in other fields and professions. Elective is a medical term used in the medical field for placements.
Yeah, and they're the same thing. They're all these fancy words. Essentially, if you spend some time in a hospital, you can call it whatever you want.
Yeah.
If you get some time to spend in a hospital,
Yeah.
and get a letter at the end of it, acknowledging it, you can call it whatever you want.
Yeah. I think the other word a lot of people get hit with is clinical observationship. So I think again, honestly, once you go in there, it's you're doing the same stuff. You're
Yeah,
always doing the same stuff. So you're right. Okie dokie. So I think somebody also asked, is there any way of going straight into the FY1 program? So something set up similarly to the FY2 standalone, but to do it.
So I didn't apply for the FY1 program because for you to apply for an FY1 program, you have to apply the previous year October, and I wasn't aware. So by the time I thought of it, that deadline had passed. For the FY2 program, you have to apply in January. So I made that deadline. Could you apply for the FY1 program? I'm not sure if we're allowed to. I'm sorry. Just because our degree encompasses the FY1, but I would say try and do an FY1 trust post or get some sort of experience to compensate for the gap, to just bridge that gap between studying in Bulgaria and start working as a SHO in the UK. Do something, because that's a very big gap. I couldn't stress to you how big that gap is. So yeah, I would say definitely do something to bridge that up.
Okay, lovely. I'm just going through the questions, so I think a lot of people are just saying thank you and great job. So I'll relay that for a second. I think somebody also asked a really interesting question regarding, is it actually worth studying abroad if it puts you at a disadvantage?
Well, let's be all honest there. We were studying abroad because we couldn't get a place in the UK. So, if we really want to pursue a career in medicine, then and you can't get a place in the UK, then yes, study abroad. But we all are aware that, studying abroad, it wasn't our first choice. So we can't expect to be at an advantage when we come back. It is, again, our initiative that's going to sort of put us toe to toe with doctors in the UK. And it's so yeah, I mean, it's we have to go out to our way to stand toe to toe with them. But yeah, no, we are at a disadvantage. Personally, we are. But yeah, it's not a disadvantage we can't bridge.
I absolutely agree, but I think one thing I've emphasized a lot over the past couple of months in these webinars is that though we have the disadvantage in a certain way where we're not familiar with the system, I think the advantage we have is I think we're tougher men for it. And I use men as a generalized term over here. But I think the people I've seen, even like yourself, go back. I think the funny thing, this is one thing I noticed, and I actually pointed this out to a colleague who graduated from the UK when I was doing my elective. And because Sorubaan here, he was in and out the ward, he was getting on with work and like not a single complaint. And I think I had every doctor around me at some point stop and just huff and puff because that's what the job will do to you. So I was just like, that's the thing, like you definitely have thicker skin for it. And at the same time, when I was in Basildon, one thing I realized was almost every consultant was IMG. Almost every consultant has graduated from somewhere other than the UK when they were studying medicine, and they're all consultants in that hospital. So it's definitely possible to still get up there
100%.
and still achieve just as much. But I think you have to go through those extra hurdles when you're on the process to things. The difficulty I have is a lot of people. My big brother's a doctor as well who graduated from Glasgow University, and a lot of people think I'm at an advantage for having him, but he has absolutely no clue about what I need to do because everything is so well lined up for him.
Yeah.
The day he finished medical school, he knew exactly what he needed to do, where to go, what hospital, what position, and for us, that's all there to figure out. So when I ask him, I'm like, okay, how do I do this? He's like,
they wouldn't have
I don't know. Someone else did it for me.
Like they can't help me. My dad's a consultant. My brother's a medical student in the UK. None of them have any idea about my route.
Yeah.
They have no idea. So we have to do it ourselves. And that's something, but one thing I do want to say is the reason I don't complain is because I consider my situation a privilege. I consider, being in the FY2 standalone program, working in the UK after studying in Bulgaria, I consider that as a privilege. So I don't think there's a reason for me to complain. Even when things get hard, I always I know it's a cliche, but count my blessings. So I don't like complaining. When you saw me and stuff, I was stressed. I was super stressed when you saw me. I was on outliers that day. So I was looking at every orthopedic patient in the hospital that are not in the orthopedic ward. So there were about 80 patients, and I was looking at every single patient within those time, and I was stressed. But again, I think what studying in Bulgaria or studying in Europe builds us is a character, build like personal development, builds our character, perseverance. And we don't complain, we just get on with it. And there's a good point about, you said IMG is being consultant, because I want to be a consultant one day, and me studying in Bulgaria doesn't deter me from, I don't think of myself any less than studying in the UK. So very good point.
I think that was the funny thing, because when I was over there, I felt so privileged to be there, and I was so happy to be there. I think I had 3 days over the weekend where I was in on days, and I was also in on calls at night. And the junior doctors were just turning around like, what is this guy doing?
Yeah, I know.
Has he lost it? Have they really lost it? Like, you're here on your own dime. On your own time.
You're not getting paid for it.
I'm literally paid to be there, right?
Yeah,
this is a concept they cannot get their mind around, because once you get into one of the UK medical school, you're pretty much guaranteed to be spoon-fed. So you have no internal drive, to the point where I've met a lot of SHOs in that hospital who are borderline deciding if they want to even be in medicine or not. And I'm just like, what are you talking about? I just really don't get it. But That's what I'm saying. It gives you a different
The thing
sort of
is,
mindset.
what you're doing, going out of hours and doing, it's going to help you so much. It's going to
Yeah,
help you so much. In a few years' time, when you work as a doctor, you're going to look back and think, this,
yeah,
what I've seen, you're going to be in such a good, even if it doesn't directly correlate, you know what's going on. You know what out of hours services, you know what nights look like, you know what on calls look
exactly.
like. Very important. So
Yeah,
yeah, hold on.
absolutely. And I think that's something I would recommend to pretty much anyone going for an elective. Try and get into those night on calls, because you will see things that you will not normally see at daytime. Because it's like, imagine an A&E, but the whole hospital's an A&E. Because you're only getting bleeped when it's an emergency. You're only going to a
Yeah.
place when it's an emergency. So it's one emergency after another. And sometimes you're dealing with like 3 or 4 met calls back to back and at the same time. So it's madness. And it gets to the point where it's never enough doctors. So they even ask you to get hands on and you have
Mm.
to glove up.
No, it's
So
very good.
absolutely.
No, it's very important that you did though.
Yeah.
These are experiences that normal medical students don't.
Yeah. I
Um,
think normal medical students, even over here, like they really don't, unless you go out your way to actually ask for it. But for me, this wasn't even part of my placement. I literally just walked into the hospital at like, I think it was 11 p.m. or something. And I ran into a junior doctor and I just asked her, I'm like, do you have an interesting case? She's like, yeah, somebody with severe epigastric pain. And I'm like, can I tag along? They're like, okay. They never have an issue with it. They're
no,
just like, cool. Like they need the company. They're walking around hospitals by themselves.
100%.
Lovely. I think the next one is a bit of a sort of question directed to you specifically, but I think a lot of people are asking about. Actually, you know what? I really do want to address this because I feel as if this is an important question somewhat. But somebody asked, is it safe to study in Sophia, especially for women?
Okay. Um, I know I've got mates who are girls and who studied and they've progressed and I don't look, I can't speak from personal experience because obviously I'm not a girl, but I don't see why not. I don't see why not. It's about company and making sure it's fine, but I don't see why it's not safe. So I'd recommend it. But before you go and study, I'd say go and see the city for a few days with your family and
Yeah.
make an informed decision. But personally, I wouldn't think there is.
I think I've just heard just about the same, really, because I mean, there has been incidents. If I'm honest, there has been incidents. But whenever I do ask about them, it was really a result of sheer recklessness. And I
Yeah,
don't I don't say this out of any ego or anything like that, but it was just somebody who was, it could have happened to anyone at that point. It could have happened to you in the UK. So I think anywhere you go, there's a standard level of risk you're facing, but it's just important to take those precautions, as in there is a big community over there of students. And there are people who you can have around you and surround yourself with that can act together and protect you, as well as you protecting them. So I've always noticed that, like, if somebody walks into our campus and some Bulgarian person and starts throwing his weight around, I don't think a lot
yeah,
of students would just sit down and watch that.
yeah.
You have numbers and we have numbers
Essentially,
now.
essentially, what we're saying is don't be stupid.
Yeah,
Okay, you went there for one reason, and just don't do anything stupid. You'll be
yeah,
fine.
yeah. And know the place, because
Yeah,
it's a massive cultural shock. It's a massive cultural shock because when you go to the UK, I think when you move from the UK to Bulgaria, the one thing you have to leave behind is your entitlement.
yeah,
you know, because you can't talk your way out of trouble. People aren't as compliant. People won't do something just because you've asked them to.
mm,
I've been in situations where I've seen people who literally just got refused, waiters who refused to serve them,
mm,
and there's no one you can complain about it. One, because you don't know how to. Two, because even if you do, there's not great likelihood they'll take it seriously.
mm.
So know where you are and react accordingly. Okay, I want to move on to our
Can I
last.
ask a question? Can I
Yes.
answer a question? I think it's a really good question
Yeah.
someone asked. I think someone asked about the foundation program,
Mhm.
how to apply. Was it to hospitals or deaneries?
Okay.
So the question is, the answer is, you don't apply to hospitals or deaneries. You apply through it's called Oreo. You apply through the centralized system called Oreo, and you go into their website, and it has deadlines. Like I said, the foundation year 2 standalone program deadline is beginning somewhere in the middle of August. It begins at the start of August. It's a 2-week process, 2-week deadline. Sorry, not deadline, the 2-week window where you can apply. And what you apply for is essentially you do the application form in for the FY2, and they'll get back if you've met their criteria. If you want to see those criteria, you're more than welcome to see on Google. It's about IELTS, which IELTS, your IELTS grades have to be higher than what is required for GMC. I think
I think it was 6.5 or 7.
No, 7.5 in every module.
7.5.
Yeah, 7.5 in every module. And also you need to have, there's something else, I can't remember now. So look at the criterias, and you need to have a full GMC license, which is what we're going to get, what you guys will get. And once you do that, they will give you, they'll set you up for your exam, which is, what exam is it called? One of these exams, what is it called? Situational judgment, SJT exam.
SGTs, yep.
So I did my SJT exam in March. We have to prepare for it. The higher the score you get, and after the exam, you get invited for an interview. So they collate your SJT marks and your interview grades together, and they rank you. I was 78th in the country, and that's why I got my first choice preference in Basildon Hospital. So do well in your SJT, do well in your interview, you'll get your first choice preference, and that will set you up nicely for your specialization as well. Because if you go to a good deanery, you're more than likely to get a good specializing specialty.
I think we've got most of them, to be honest. Definitely. I think what I will do is you guys have our emails already, so feel free to email us any questions, and we can forward them on to Dr. Baskaran, and he can email you back if whenever he has the time. If you guys, because obviously, you guys will have more interesting questions which you'll think up later on. I know I always do. I'm like, I should have asked that. So yeah, no, I think absolutely we can do that. I just want to again ask everyone to make sure you filled in the feedback forms. You guys will get certificates of attendance, and I want to give a big thank you to Dr. Baskaran. I'm really looking forward to working with him again, and I think he's really out there doing a good job representing us IMGs, because I think this was one of my worries when I walked into my placement. I'm like, oh God, I'm gonna make a fool of myself, and then they're gonna have this built up opinion of people who studied in Europe, and specifically in Eastern Europe. And that was one of my biggest worries, like as soon as I got over there, like, and I think that's one of the things that actually encouraged me to go on to nights and work a little harder, was when they saw it, they're like, all right, okay, you guys are relentless. And I'm sure whenever another Bulgarian pops up, they'll share the mutual respect. People like Dr. Baskar have set that example out. So definitely. Is there any closing comments you want to give, Dr. Baskar?
Well, generalize, keep working hard, just keep thinking about what you want to do post university, where you want to work, what you want to do, cater your portfolios, but also most importantly, just enjoy what you're doing, whatever you're doing, just keep enjoying what you're doing. That's really important.
Absolutely, I couldn't agree more. Okay, guys. Well, I think we'll have our next one in September, probably again towards the end. So I think that's just because well, I mean, we're at the end of August, so it'll definitely not be at the beginning. It'll be towards the end, and I think we already have a very interesting topic laid out, so it'll be a lot of fun. Again, I want to thank you all for being here. Take care, stay safe. We still have a pandemic going on. Don't forget it. Wear your masks. Ask the doctor. I'm sure he'll say the same. But yeah, okay, lovely. I will leave the webinar on for anyone who wants to fill in the feedback form, and probably just end it after a couple of minutes.
Yeah.
Thank you again, Doctor.
Take care. Good luck, guys. See you soon. Nice one, Mohsin.